if you break a bone or, catch a virus, your body's generally pretty good at letting you know.
Oh, yeah. A blaring alarm goes off.
Right. You get sharp pain, swelling, maybe a sudden fever. The signals are impossible to ignore, and the cause and effect are just right there in front of you. But what happens when an entire systemic shield is just suddenly pulled away from your body and the alarm stays completely silent?
Well, you end up with a medical crisis that honestly masquerades as a mild inconvenience. I mean, people tend to look at the surface level symptoms and totally miss the fact that a fundamental structural shift is happening underneath.
And that structural shift is our mission for today's deep dive. We are looking at the long-term whole-body impact of untreated early menopause and premature ovarian insufficiency, or POI.
Right.
We've got this fascinating stack of sources here. Clinical guidelines from the British Menopause Society, the American Heart Association, ESHRE, and a bunch of recent academic studies. And pulling all of this together reveals a really profound truth.
It really does.
For decades, the medical world and the public have treated early menopause as basically just a gynecological issue. But this is actually a massive metabolic shockwave that alters the brain, the heart, and the bones.
Yeah, it forces a total reframing of what estrogen actually does for you. I mean, when estrogen levels drop decades earlier than the human body biologically expects, whether that's happening spontaneously or surgically through something like a bilateral oophorectomy, it doesn't just halt reproductive capability.
Right.
It strips the body of a master regulator.
I was actually trying to wrap my head around this while reading the guidelines because, everyone knows estrogen is a reproductive hormone.
Sure.
But looking at the sheer number of estrogen receptors scattered across the human body, from the nervous system all the way down to the skeletal framework, it seems more like estrogen is the body's chief maintenance officer.
Let's actually run with that maintenance officer idea because it illustrates the mechanism perfectly. The female body is genetically programmed to have this specific maintenance protocol running actively until roughly the early 50s. Estrogen goes into the cells and regulates gene expression. So it tells cells when to divide, when to repair, and how to manage inflammation.
Which is a huge job.
Exactly. And when you fire that maintenance officer 10 or 20 years early, the building doesn't just collapse the next morning.
Right, it's not instant.
No, but the structural degradation accelerates at a terrifying pace.
So we look at the physical framework of that building, like the skeletal system. The data in these sources is incredibly sobering.
It's stark.
Yeah, the European guidelines put a number on it, noting that up to 15% of women with POI will develop osteoporosis. And there was this longitudinal analysis out of Australia that showed a 37% higher risk of osteoporosis and a 45% higher risk of fractures by their late 60s.
Which are massive increases.
They really are. And I understand that bone density drops without estrogen, but what is the actual biological mechanism there? Like, what is physically happening inside the bone?
Well, to see the mechanism, you have to look at the constant renovation project happening in your skeleton. Because bone isn't a static piece of chalk, right?
Right.
You have a demolition crew. These are cells called osteoclasts that clear away old microdamaged bone. And then you have a building crew, osteoblasts, that lay down fresh new bone.
Okay, demolition of builders. Got it.
Right, and estrogen keeps that demolition crew on a strict schedule. It actually promotes programmed cell death in those osteoclasts, just ensuring they don't stick around too long.
So without estrogen, the demolition crew essentially goes rogue.
They work overtime, the osteoclasts live longer, and they literally dig deeper trenches into the bone tissue.
Oh, wow.
And the building crew simply cannot keep up with the sheer volume of bone being cleared away. So the internal architecture of the bone becomes super porous and fragile.
Which totally explains why early intervention is so critical. I mean, a woman in her 20s or 30s who develops POI might not have even hit her peak bone mass yet. She's entering a state of hyperdemolition with a foundation that wasn't even fully built to begin with.
And this is where the silence of the condition becomes so dangerous. The guidelines stress immediate bone density scans at diagnosis because you cannot feel those trenches being dug inside your bones.
Yeah, if you're listening to this and wondering how you'd even know this was happening, I mean, that's the scariest part. It's like having termites in your walls.
That's a great way to put it.
You have absolutely no idea. Your structural beams are completely hollowed out until you lean against the wall and it just snaps.
Right, it's invisible until it's a crisis.
But there was one detail in the risk factors that completely threw me. The data shows leaner women actually lose bone significantly faster in this state.
Yeah, that surprises a lot of people.
I would have thought carrying more physical weight might strain the bones. But it seems like adipose tissue, body fat is somehow acting as a buffer.
It is, because adipose tissue is hormonally active. It's not
Ah.
just stored energy. Fat cells contain an enzyme called aromatase. And this enzyme has a very specific job it can take, circulating androgens, which are male hormones naturally produced in the adrenal glands, and convert them into a weaker form of estrogen called estrone.
Wait, so women with a higher BMI essentially have a backup generator for estrogen.
A very small one, yes. That background hum of estrone provides just enough of a chemical signal to slightly rein in those rogue osteoclasts we talked about.
Wow.
But leaner women simply do not have that adipose tissue factory. So when their ovaries stop producing estrogen, the drop is absolute. The demolition crew faces zero resistance, making their bone loss incredibly precipitous.
That makes the mechanics of this so much clearer. But of course, the skeleton isn't the only system relying on this maintenance protocol. The same biochemical environment that allows the bones to crumble is simultaneously attacking the body's cardiovascular plumbing.
And the numbers here are frankly alarming.
Yeah, the stats from the American Heart Association and recent studies are wild.
We are looking at an incredible shift in cardiovascular risk. I mean, historically, heart disease has been heavily framed around male physiology. But when a woman loses her estrogen shield early, her cardiovascular environment fundamentally degrades.
I was looking at the data out of Northwestern medicine, and they found that natural menopause before age 40 comes with a 40% higher lifetime risk of developing coronary heart disease.
It's huge.
And then an Adventist Health study found an 80% increased risk of fatal ischemic heart disease if menopause hits between 35 and 40.
80%.
Yeah. I want to understand the timeline here, though. If you lose estrogen at 38, does your heart attack risk spike at 39? Or is this more like peeling the rust proofing off a car way too early and just leaving it out in the rain?
The rust-proofing concept is the reality. It's a slow, compounding metabolic degradation. Let's look at how estrogen protects the blood vessels.
Okay.
Estrogen upregulates an enzyme in the endothelial cells as the inner lining of your arteries. That enzyme produces nitric oxide, which is a really powerful vasodilator.
Meaning it opens things up.
Exactly. It keeps your blood vessels relaxed, flexible, and wide open.
So when the estrogen drops, the nitric oxide drops, and the pipes literally stiffen.
The pipes stiffen, the blood pressure starts to creep up, and simultaneously, the way the body handles lipids changes entirely.
Because of the estrogen loss.
Right. Without estrogen's regulatory effect, you start to see a drop in HDL, the good cholesterol, and a rise in LDL. And these LDL particles are more likely to oxidize and stick to those newly stiffened, inflamed artery walls.
Man.
So the longer you exist in that estrogen-depleted state, the more plaque you build. By the time a woman who experienced early menopause reaches her 50s, her arteries might look like the arteries of someone 20 years older.
The Northwestern data also brought up a major demographic disparity that I think is really crucial to highlight. They found that premature menopause is 3 times more common in Black women, sitting at about 15.5% compared to white women, or it's under 5%.
Yeah, that's a very significant finding.
And the researchers were very clear that this isn't just some inherent biological flaw.
No, absolutely not. It reflects the compounding nature of life course exposures. So systemic inequities, chronic environmental stress, and disparate access to preventative health care, they all manifest biologically.
Right.
When a demographic is carrying 3 times the burden of early cardiovascular vulnerability, it completely alters how aggressive we need to be with early screening and vascular health management in those communities.
We really do. So we have a physical framework that is actively hollowing out and cardiovascular plumbing that is stiffening and clogging. That brings us to the control center.
That brain.
Yes, the brain. The neurological data in these sources might be the most paradigm-shifting part of this entire deep dive.
The neurology of estrogen is a rapidly evolving field right now, and the implications for cognitive longevity are profound. Estrogen doesn't just float around the brain. It actively modulates the cholinergic system.
And that's what exactly.
It's the neurotransmitter network responsible for memory, learning, and attention.
Which gives intense context to those UK Biobank findings. The data showed that women entering menopause before 40 are 35% more likely to develop dementia of any type.
Right.
And if it happens before 45, they are 1.3 times more likely to develop early onset dementia before the age of 65.
It's frightening data.
There was also a specific study focusing on surgical menopause. So the removal of both ovaries showing a massive 3.2 times higher risk of mild cognitive impairment. Why does the brain react so violently to this?
Because you are fundamentally disrupting the brain's energy supply. The female brain is highly reliant on estrogen to metabolize glucose effectively.
Okay, so it's a fuel issue.
Exactly. Estrogen is essentially the key that turns the ignition for the brain's fuel system. When you undergo a bilateral oophorectomy, you aren't just dimming the light slowly over a few years, allowing the eyes to adjust.
Right.
You are violently yanking the power cord out of the wall.
The brain literally loses its ability to feed itself properly overnight.
It starves. The neurons experience an acute energy crisis. The brain has to frantically rewire itself to try and use alternative fuel sources like lipids.
And what does that feel like for the person?
This metabolic scramble is what triggers the severe brain fog, memory deficits, and hot flushes, which are actually neurological temperature regulation misfires.
Wait, really? Hot flushes are neurological?
Yes, they start in the brain. And over years, this chronic metabolic stress in the brain leads to higher regional tau deposition.
And tau proteins are the tangles directly linked to Alzheimer's disease.
Which is exactly why we see these elevated risks for presenile dementia and Parkinsonism. The brain is remarkably resilient, but running it without its primary metabolic regulator for decades leaves a permanent mark.
If you're a listener right now and you've experienced early menopause or you have a family history of it, hearing all of this, the bone degradation, the vascular stiffening, the neurological starvation, it probably feels terrifying.
Oh, I'm sure it does.
It sounds like an unavoidable cliff. But the clinical guidelines from NICE, ESHR, and the American Society for Reproductive Medicine are incredibly unified on how to rewrite this entire trajectory.
They are. The medical consensus is absolute here. The primary intervention is hormone replacement therapy, or HRT, sometimes referred to simply as hormone therapy. And the nuance of why we use it here is vital.
Right, because this isn't about anti-aging. It's not some biohacking trick to stay forever young.
Not at all. We are talking about physiological dosing. The goal of HRT for a woman with POI is to provide estrogen right up until the natural age of menopause, around 51.
Okay.
You are not artificially altering a normal state. You are restoring a baseline deficit. You are literally giving the body the fuel it is genetically screaming for.
And the data shows it works. I mean, the hazard ratio for cardiovascular disease in women with early menopause dropped from a staggering 3.6 down to just 1.2 with HRT use.
Which is incredible.
It puts the osteoclast back in check, stopping the bone demolition. It restores the glucose metabolism in the brain. But I have to bring up the cultural elephant in the room here.
I know exactly where you're going.
If a woman is 38 and her doctor suggests HRT, she has probably spent the last 20 years reading terrifying headlines about how HRT causes breast cancer.
Yes. And the shadow of those older studies, particularly the misinterpretation of the Women's Health Initiative in the early 2000s, has done just incalculable damage to women's health.
It really has.
Those headlines were based on studies of women in their 60s, many of whom had existing cardiovascular disease, who were given pharmacological doses of hormones decades after their natural menopause.
It's a completely different cellular environment.
Entirely different. Giving hormones to a 65-year-old body that has adapted to not having them carries totally different risks than replacing hormones in a 35-year-old body that is actively shutting down without them.
That distinction is so important.
The guidelines are emphatic. For women with POI, the benefits of taking HRT until age 51 massively outweigh the risks. This is what the ASRM calls the window of opportunity.
So by denying a younger woman HRT out of a misplaced fear of a slight breast cancer risk, we are actively increasing her risk of dying from a major cardiac event, or shattering her hip at 60, or developing Alzheimer's.
Sadly, yes.
We're ignoring a systemic fire because we're worried about the toxicity of the fire extinguisher.
That sums up the clinical frustration perfectly, and it requires a holistic management strategy. HRT is the chemical foundation, sure, but the sources also heavily emphasize mechanical and lifestyle support.
Because if the osteoblasts, the bone builders, are finally getting their estrogen signals to get back to work, they still need the raw materials and the mechanical stress to build effectively.
Exactly, which means heavy weight-bearing exercise to stimulate bone density, rigorous cardiovascular conditioning to keep whatever nitric oxide you have flowing, and ensuring adequate calcium and vitamin D to provide the literal building blocks for the skeleton.
Looking at all of this together, it is just a masterclass in how wildly interconnected human biology is. The ovaries don't exist in a vacuum.
No, they don't.
When they power down early, the structural integrity of the bones takes a hit. The cardiovascular pipes lose their flexibility, and the cognitive wiring struggles to find fuel.
It demands that we stop siloing women's health care. I mean, you cannot treat a patient's missing periods without simultaneously considering her 50-year fracture risk and her neurological longevity.
Which leaves us with a totally different paradigm for how we view this phase of life. If we stop looking at menopause simply as the closing of a reproductive window and start viewing it as a critical, systemic, metabolic transition, how does that change the conversation you have with your own doctor?
It changes everything.
How does it change the way you look at a missed period or a sudden onset of brain fog in your late 30s? Don't wait for a broken bone or a cardiac event to tell you something is wrong underneath. Keep asking questions, dig into your family history, and advocate for your baseline. Because as we've learned today, the maintenance of your entire physical and cognitive framework depends on it.